Block. Simulation 8. You know the rhythm. Read the command first. Scan the clues. Build fast, lock, and move. 20 questions, 30 minutes. Clock starts now. Using the Fick principle. What is the cardiac output? A patient in the cardiac catheterization lab has the following measured: oxygen consumption 250 ml/min, arterial O2 content 20 ml ADO, and mixed venous O2 content 15 ml ADO. Read the command cardiac output using the Fick principle. Oxygen consumption 250, arterial venous oxygen difference 20 minus 15 equals 5 ml ADL. The Fick principle states that cardiac output equals oxygen consumption divided by the arteriovenous oxygen content difference. Oxygen consumption is 250 milliliters per minute. The arteriovenous difference is arterial content 20 minus venous content 15, which is 5 milliliters per deciliter. Be careful with units. Convert 5 ml ADL to 50 ml L, since cardiac output is in liters. So cardiac output equals 250 divided by 50, which is 5 liters per minute, a normal value. Correct answer is B. The Fick principle is conceptually simple. The amount of oxygen the body consumes must equal the amount delivered by the blood, which is cardiac output times how much oxygen each unit of blood drops off. The classic trap is the unit conversion. Content is given per deciliter, output is per liter, so multiply by 10. The answer is a normal cardiac output of 5 liters per minute. Why is the splenic flexure particularly vulnerable in this condition? A 70-year-old woman presents with 2 days of crampy left lower quadrant pain and bloody diarrhea. She has known atherosclerosis and recently had an episode of hypotension. Colonoscopy shows mucosal edema, hemorrhage, and patchy necrosis localized to the region of the splenic flexure, with sparring of the rectum. Read the command. Why the splenic flexure is vulnerable: elderly, atherosclerosis, hypotension, then bloody diarrhea and necrosis at the splenic flexure, ischemic colitis at a watershed area. The splenic flexure is a watershed zone, the border between the territories of two different arteries. The proximal colon up to the splenic flexure is supplied by the superior mesenteric artery, and the distal colon from the splenic flexure onward is supplied by the inferior mesenteric artery. Watershed areas sit at the very ends of both arterial supplies, where perfusion pressure is lowest. During an episode of low flow, hypotension, shock, or atherosclerotic narrowing, these border zones are the first to become ischemic, which is why ischemic colitis classically localizes to the splenic flexure, D&E, rectosigmoid junction. The correct answer is C. The two classic colonic watershed areas are the splenic flexure between the SMA and IMA, and the rectosigmoid junction between the IMA and the internal iliac. The rectum is typically spared in ischemic colitis because it has a rich collateral supply from the internal iliac. Crampy pain plus bloody diarrhea after hypotension localized to the splenic flexure is the classic watershed ischemic colitis picture. A deficiency of which vitamin and its associated coenzyme role explains this presentation. A 54-year-old man with chronic alcohol use is brought in confused. Exam: horizontal nystagmus, bilateral lateral rectus palsy, rhabdomyoplegia, and an ataxic gait. He is given IV fluids containing dextrose, after which he becomes markedly worse. Read the command: which vitamin and coenzyme role? Alcoholic, confusion, ophthalmoplegia, ataxia, worsened by dextrose without thiamine, Wernicke encephalopathy, thiamine deficiency. This is Wernicke encephalopathy from thiamine. Vitamin B1 deficiency, classically in chronic alcoholics who have poor intake and impaired absorption. The triad is confusion, ophthalmoplegia with nystagmus, and ataxia. Thiamine is the essential cofactor for several enzymes of glucose metabolism: pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase in the TCA cycle, and transketolase in the pentose phosphate pathway, plus branched-chain ketoacid dehydrogenase. Without thiamine, these enzymes fail, and the brain, heavily dependent on glucose oxidation, is injured. The correct answer is B. The clinical pearl in this question is critical. Giving GLU-CoS to a thiamine-deficient patient can precipitate or worsen Wernicke encephalopathy because the glucose load consumes the last remaining thiamine to be metabolized. Therefore, always give thiamine before or with dextrose in at-risk patients. Untreated, Wernicke can progress to irreversible Korsakoff syndrome, memory loss with confabulation. Which nerve was injured? A 30-year-old man falls and strikes the medial aspect of his elbow. Afterward, he has numbness of the little finger and the medial half of the ring finger, weakness of finger abduction and adduction, and a claw hand, deformity that worsens when he tries to extend his fingers. He cannot hold a piece of paper between his thumb and index finger without flexing the thumb, positive Froment sign. Read the command. Which nerve was injured? Medial elbow trauma, little and medial ring finger numbness, weak finger abduction, adduction, claw hand, positive Froment sign, ulnar nerve at the elbow. The ulnar nerve passes behind the medial epicondyle of the elbow, the funny bone, where it is superficial and easily injured by a blow to the medial elbow. The ulnar nerve supplies most of the intrinsic hand muscles, the interossei finger abduction and adduction, the medial two lumbricals, and the adductor pollicis. Injury causes sensory loss over the little finger and medial ring finger, weakness of finger spreading, and the claw hand. The positive Froment sign, flexing the thumb to grip paper because the adductor pollicis is weak, confirms ulnar involvement. The correct answer is E. A counterintuitive point. The ulnar paradox, an ulnar lesion at the W wrist produces a more pronounced claw than a lesion at the elbow, because a proximal elbow lesion also paralyzes the medial flexor digitorum profundus, so the fingers cannot flex as strongly into the claw. Medial epicondyle injury with claw hand and Froment sign points to the ulnar nerve. Occlusion of which artery is most likely, and which complication does the hypertension bradycardia suggest? A 58-year-old man presents with crushing substernal chest pain for 5 hours. ECG shows ST elevations in leads I3 and AVF. He becomes hypotensive and bradycardic. Troponin is rising. Read the command, which artery and which complication. ST elevations in 2, 3, AVF, inferior leads, bradycardia, and hypotension. Right coronary artery, inferior. MI with RV involvement and AV node ischemia. ST elevations in leads I3 and AVF localized to the inferior wall of the heart, which is most often supplied by the right coronary artery. The RCA also supplies the AV node in about 90% of people and the right ventricle. So an inferior MI from RCA occlusion can cause AV node ischemia, producing bradycardia and heart block, and right ventricular infarction, which presents with hypotension that is preload dependent. That is exactly this patient, inferior ST elevations with bradycardia and hypotension. Correct answer is D. A crucial management point. Because right ventricular infarction makes the patient dependent on preload, you must give FLUides and avoid nitrates, which drop preload and can cause severe hypotension. Match the leads to the artery. Anterior V1, V4 is LA, D, lateral EI, AVL, V5, V6 is left circumflex, inferior EI, 3, AVF is RCA. Inferior MI with bradycardia is the RCA. Which statement correctly pairs a drug with its effect on the glomerular arterioles? A patient with chronic kidney disease is given an NSAID for pain. A second patient with bilateral renal artery stenosis is given an ACE inhibitor. Both develop a significant decline in GFR. Read the command. Pair each drug with its arteriolar effect. NSAID constricts afferent, loses prostaglandin dilation. ACE inhibitor dilates efferent, loses angiotensin II constriction. Both can drop GFR. Glomerular filtration rate depends on the pressure gradient set by the afferent and efferent arterioles. Prostaglandins normally dilate the afferent arteriole, maintaining inflow. NSAIDs block prostaglandin synthesis, so the afferent arteriole constricts, reducing flow into the glomerulus and lowering GFR, dangerous in a kidney already dependent on prostaglandins. Angiotensin II normally constricts the efferent arteriole, which maintains glomerular pressure. ACE inhibitors block angiotensin II, so the efferent arteriole dilates, dropping glomerular pressure and GFR, dangerous in bilateral renal artery stenosis, where that efferent tone is what preserves filtration. The correct answer is E. So the two drugs lower GFR by opposite ends of the glomerulus. The clean way to remember: prostaglandins protect the afferent, angiotensin II tightens the efferent. Block prostaglandins with an NSAID and the afferent clamps down. Block angiotensin II with an ACE inhibitor and the efferent opens up. In a vulnerable kidney, either drops the filtration pressure. What is the principal mechanism by which nitroglycerin relieves his angina? A 60-year-old man with stable angina takes sublingual nitroglycerin when he develops chest pain on exertion. His symptoms resolve. He is counseled about headache and the need for a nitrate-free interval to avoid tolerance. Read the command. Principal mechanism of nitroglycerin in angina. Stable angina relieved by nitroglycerin. Headache, tolerance, venodilation, reducing preload, and oxygen demand. Nitroglycerin is converted to nitric oxide, which activates guanylate cyclase, raising cyclic GMP and relaxing vascular smooth muscle. At therapeutic doses, it preferentially dilates veins. Venodilation pools blood in the venous system and reduces venous return, preload. Lower preload means a smaller ventricular volume and lower wall tension, which reduces myocardial oxygen demand. Since angina is a mismatch between oxygen supply and demand, decreasing the demand relieves the ischemic pain. This preload reduction is the dominant antianginal mechanism. The correct answer is A. The throbbing headache comes from cerebral vasodilation, and tolerance develops with continuous exposure, so patients need a daily nitrate-free interval. Note that nitrates are contraindicated with PDE5 inhibitors like sildenafil. The combination causes severe hypotension and should be avoided in right ventricular infarction, where preload is essential. The preload reducing venodilation is the core mechanism. What is the most likely diagnosis? A 55-year-old man presents with fatigue and early satiety. Exam shows massive splenomegaly without significant lymphadenopathy. CBC, pancytopenia. Bone marrow aspiration yields a dry tap. Peripheral smear shows lymphoid cells with fine, hair-like cytoplasmic projections. The cells stain positive for tartrate-resistant acid phosphatase trap. Read the command. Most likely diagnosis: massive splenomegaly, pancytopenia, dry tap, hairy cytoplasmic projections, trap positive, hairy cell leukemia. Hairy cell leukemia is an indolent B-cell neoplasm of older adults. The malignant cells have characteristic fine, hair-like cytoplasmic projections on the smear, and they classically stain positive for tartrate-resistant acid phosphatase. Trap. Two features dominate the presentation: massive splenomegaly because the cells infiltrate the splenic red pulp, and pancytopenia from marrow infiltration and splenic sequestration. The marrow is so infiltrated with fibrosis that aspiration fails, the classic dry tap, requiring a biopsy. Notably, lymphadenopathy is usually absent. The correct answer is C. Hairy cell leukemia is driven by the BRAF V600E mutation and responds dramatically to the purine analogs cladribine or pentostatin. The discriminating combination: hairy projections, trap positivity, dry tap, massive splenomegaly without lymphadenopathy, separates it from CLL, which has smudged cells and prominent lymphadenopathy, and from CML, which has a high white count with myeloid maturation. Hairy cells plus trap equals hairy cell leukemia. Which organism is responsible? A 65-year-old smoker who recently stayed at a hotel with a contaminated air conditioning system develops high fever, cough, and confusion. He also has diarrhea. Labs: hyponatremia, Na, 28. Chest x-ray shows patchy infiltrates. Sputum stain shows many neutrophils but few organisms. The organism is a gram-negative rod that requires charcoal yeast extract, agar with iron and cysteine, and is detected by a urine antigen test. Read the command. Which organism? Hotel, AC water exposure, pneumonia with confusion, diarrhea, hyponatremia, charcoal yeast extract agar, urine antigen, Legionella pneumophila. Legionella pneumophila causes Wegener's disease, a severe atypical pneumonia. It is a gram-negative rod that stains poorly, which is why the gram stain shows many neutrophils but few visible organisms. It requires special media, buffered charcoal yeast extract agar, supplemented with iron and cysteine, to grow. It is transmitted through aerosolized water from air conditioning systems, cooling towers, and hot tubs, not person to person. The classic clinical triad beyond pneumonia is high fever with relative bradycardia, GI symptoms like diarrhea, and neurologic findings like confusion, plus hyponatremia. The correct answer is B. The urine antigen test is the rapid diagnostic of choice. Treat with a macrolide or a respiratory fluoroquinolone. The combination of an atypical pneumonia with GI and CNS symptoms, hyponatremia, and a water source exposure is the signature of Legionella. The special media requirement and urine antigen seal the diagnosis. Which hormonal change directly triggers ovulation? A 26-year-old woman is being evaluated for her menstrual cycle. On approximately day 13 of a 28-day cycle, a hormonal event triggers ovulation roughly 24-36 hours later. Read the command. Which hormonal change triggers ovulation? Mid-cycle event 24-36 hours before ovulation. The LH surge driven by estrogen-positive feedback. Ovulation is triggered by the luteinizing hormone surge. During the follicular phase, the growing dominant follicle secretes increasing estrogen. For most of the cycle, estrogen exerts negative feedback on the pituitary, but once estrogen rises above a critical threshold and stays high for a sustained period, the feedback switches to positive. High estrogen now stimulates a massive release of LH from the pituitary. This LH surge, occurring around day 13 to 14, triggers ovulation roughly 24 to 36 hours later. The follicle ruptures and releases the oocyte. The correct answer is D. The switch from negative to positive feedback by estrogen is the key concept and the most tested point. After ovulation, the ruptured follicle becomes the corpus luteum, which secretes progesterone to maintain the luteal phase and prepare the endometrium, but progesterone follows ovulation. It does not trigger it. The estrogen-driven LH surge is the direct trigger of ovulation. What is the underlying histologic pattern? A 68-year-old man presents with progressive exertional dyspnea and a dry cough over 1 year. Exam shows fine bibasilar, Velcro, inspiratory crackles and clubbing. PFT show a restricted pattern with reduced DLCO. High-resolution CT shows subpleural, basal-predominant reticular opacities with honeycombing and traction bronchiectasis. No exposure or autoimmune cause is found. Read the command underlying histologic pattern. Older adult, progressive dyspnea, Velcro crackles, clubbing, restricted PFTs, honeycombing on CT, no other cause. Idiopathic pulmonary fibrosis, the UIP pattern. Idiopathic pulmonary fibrosis is a progressive fibrosing interstitial lung disease of older adults, and its defining histologic pattern is usual interstitial pneumonia. UIP. UIP shows patchy, heterogeneous fibrosis with a subpleural and basal distribution, scattered fibroblastic foci representing active fibrosis, and architectural destruction with honeycomb change. The result is stiff, non-compliant lungs, a restrictive pattern with reduced lung volumes and impaired gas transfer, low DLCO. Clinically, it produces the Velcro-like inspiratory crackles, clubbing, and slowly progressive dyspnea seen here, with no identifiable exposure or autoimmune trigger. The correct answer is A. The CT findings, subpleural basal reticulation, honeycombing, and traction bronchiectasis, correspond directly to the UIP pattern and can be diagnostic without biopsy. Choice C, non-caseating granulomas, is sarcoidosis. Choice D, diffuse alveolar damage with hyaline membranes, is ARDS. Antifibrotics like pirfenidone and nintedanib slow progression. The UIP pattern is the histologic hallmark of IPF. Which structure is involved? Given the constellation of cranial nerves affected together, a 45-year-old man with poorly controlled diabetes develops a severe facial infection. He now has fever, headache, and progressive findings, drooping of the right eyelid, an inability to move the right eye in any direction, a fixed dilated pupil, and decreased sensation over the forehead and cheek. The left eye is normal. Read the command. Which structure, given multiple CN involved together? Ptosis, complete ophthalmoplegia, fixed dilated pupil, V1 and V2 sensory loss. Cavernous sinus syndrome. The cavernous sinus is a venous channel beside the sella turcica through which several cranial nerves travel together, cranial nerves 3, IV, and VI double, controlling all eye movements, plus the V1 and V2 branches of the trigeminal nerve, and the internal carotid artery with sympathetic fibers. A lesion here therefore knocks out multiple cranial nerves at once, complete ophthalmoplegia, 3 IV, VI, 2 cis, and a dilated pupil 3, and sympathetics, and sensory loss over the forehead and cheek, V1 and V2. The simultaneous involvement of all these nerves on one side localizes precisely to the cavernous sinus. The correct answer is E. The setup is classic. A facial or sinus infection, especially in a diabetic, can spread retrograde into the cavernous sinus, causing septic cavernous sinus thrombosis, a feared complication. The key reasoning principle is that when multiple eye movement nerves plus trigeminal sensory branches fail together on one side, the lesion is at the cavernous sinus where they all converge. What is smoking in this scenario, and how is it best addressed in study design? A study finds that coffee drinkers have a higher rate of lung cancer than non-coffee drinkers. However, coffee drinkers are also far more likely to be smokers, and smoking causes both coffee-associated behavior and lung cancer. Read the command, what smoking is and how to address it. A third variable, smoking, associated with both coffee and lung cancer, distorting the association, confounding. Smoking is a confounder. A confounder is a third variable that is associated with both the exposure and the outcome, and is not on the causal pathway between them. It creates a spurious or distorted apparent association. Here, smoking is linked to coffee drinking and independently causes lung cancer, so it makes coffee look harmful when smoking is the real driver. Confounding is addressed in several ways. At the DE-assigned stage by randomization, which balances confounders across groups, restriction, or matching, and at the analysis stage by stratification or multivariable regression adjustment. The correct answer is E. Distinguish confounding from effect modification. An effect modifier changes the strength of the true association across its levels and is a real finding you report by stratum, not something you correct. A confounder is a nuisance you want to eliminate. Randomization is the most powerful tool because it balances both known and unknown confounders. Smoking distorting the coffee cancer link is textbook confounding. Which substance accumulates in this disease? A 1-year-old boy presents with hepatosplenomegaly, anemia, thrombocytopenia, and bone pain with a femoral lytic lesion. Bone marrow shows enlarged macrophages with a characteristic crumpled tissue paper appearance of the cytoplasm. Enzyme assay shows deficient glucocerebrosidase activity. Read the command, which substance accumulates? Hepatosplenomegaly, bone involvement, crumpled tissue paper macrophages, deficient glucocerebrosidase, Gaucher disease, accumulating glucocerebroside. Gaucher disease is the most common lysosomal storage disease, caused by deficiency of glucocerebrosidase, also called beta-glucosidase. The enzyme normally breaks down glucocerebroside, so when it is deficient, glucocerebroside accumulates inside macrophages throughout the body. These lipid-laden macrophages are the Gaucher cells, with cytoplasm that has a characteristic wrinkled or crumpled tissue paper. Appearance. They infiltrate the liver and spleen, hepatosplenomegaly, the bone marrow, anemia, and thrombocytopenia, and bone itself, causing avascular necrosis and lytic lesions like the femoral lesion here. The correct answer is C. Match the lysosomal diseases by their accumulated substrate and morphology. Goucher accumulates glucocerebroside with crumpled tissue paper cells. Niemann-Pick accumulates sphingomyelin with foamy cells. Tay-Sachs accumulates GM2 ganglioside. Fabry accumulates ceramide trihexoside. Goucher is also treatable with enzyme replacement therapy. The crumpled tissue paper macrophage with glucocerebroside with glucocerebrosidase deficiency means glucocerebrosidase deficiency means cystisphingomyelation. Which mechanism best explains this malignancy? A 61-year-old obese woman who underwent menopause at 55 and has a history of unopposed estrogen use and nulliparity presents with postmenopausal vaginal bleeding. Endometrial biopsy shows complex atypical hyperplasia progressing to well-differentiated adenocarcinoma with glandular architecture. Read the command. Which mechanism? Postmenopausal bleeding, obesity, unopposed estrogen, nulliparity, late menopause, endometrial hyperplasia, to adenocarcinoma, estrogen-driven type, I endometrial carcinoma. This is the classic type I endometrial adenocarcinoma, driven by prolonged unopposed estrogen stimulation. Estrogen stimulates endometrial proliferation. Progesterone normally opposes it. When estrogen acts without the counterbalance of progesterone, from obesity adipose tissue aromatizes androgens to estrogen, nulliparity, early menarche, late menopause, anovulation, or estrogen-only hormone therapy. The endomenopause, anovulation, or estrogen-only hormone therapy, the endometrium overgrows. This progresses through endometrial hyperplasia, then atypical hyperplasia, and finally to endometrioid adenocarcinoma. The cardinal presenting sign is postmenopausal bleeding, which always warrants endometrial sampling. The correct answer is A. Note the two types. Type I is estrogen dependent, lower grade endometrioid carcinoma arising from hyperplasia, with the risk factors listed. Type 2 is estrogen independent, higher grade serous carcinoma associated with p53 mutations in older, thinner women with worse prognosis. This patient's obesity and unopposed estrogen point clearly to the type I, estrogen-driven mechanism. What is the acid-base status, and what does the elevated bicarbonate represent? A 66-year-old man with severe COPD has a chronically compensated blood gas. ABG, pH 736, PaSO2 62, MHG, HCO3 34, MEKL. He is at his baseline. Read the command, acid-base status, and what the high bicarbonate represents. Cook-D, near normal pH, high PaCO2, high bicarbonate at baseline. Chronic respiratory acidosis with renal compensation. The primary disturbance is a respiratory acidosis. The COPD patient chronically retains CO2, so PaSCO2 is high at 62. In an ACU respiratory acidosis, the pH would drop sharply, but here the pH is only 736, nearly normal, which tells you compensation has occurred. The high bicarbonate of 34 is the renal metabolic compensation. Over days, the kidneys retain and generate bicarbonate to buffer the chronic CO2 retention and pull the pH back toward normal. The combination of high CO2, high bicarbonate, and a near normal pH defines a chronic, compensated respiratory acidosis. The correct answer is A. The key insight is timing. Renal compensation takes 3 to 5 days to develop fully, so a near normal pH with a high CO2 means the process is chronic. The kidney has had time to respond. The elevated bicarbonate is appropriate compensation, not a separate primary metabolic alkalosis. This is the expected steady state for a stable COTD CO2 retainer. How do the high-risk HPV oncoproteins drive malignant transformation? A 34-year-old woman with multiple sexual partners and inconsistent screening presents with postcoital bleeding. Pap smear shows high-grade squamous intraepithelial lesion. Biopsy confirms invasive squamous cell carcinoma of the cervix. HPV testing is positive for a high-risk subtype. Read the command, how HPV oncoproteins drive transformation. Cervical squamous cell carcinoma, high-risk HPV. E6 degrades p53. E7 inactivates RB. High-risk HPV subtypes, most importantly 16 and 18, cause cervical cancer through two viral oncoproteins, E6 and E7. E6 binds and promotes the degradation of p53, the guardian of the genome, tumor suppressor that normally triggers cell cycle arrest and apoptosis in damaged cells. E7 binds and inactivates the retinoblastoma protein, RB, which normally restrains progression from G1 into S phase. With both p53 and RB disabled, the cell loses its two main brakes on the cell cycle. Damaged cells are not arrested or eliminated, proliferation runs unchecked, and malignant transformation follows. The correct answer is D. Remember the pairing. E6 hits p53, E7 hits RB. Both tumor suppressors are knocked out. Persistent high-risk HPV infection is the cause of essentially all cervical cancers, and the HPV vaccine targets the high-risk subtypes to prevent this. Koilocytes, squamous cells with paranuclear halos, are the cytologic marker of HPV infection. The E6p53 and E7 RB mechanism is the molecular core. Which pharmacokinetic property explains this disproportionate rise? A 24-year-old man with epilepsy on phenytoin has his dose increased modestly. A few days later, he develops nystagmus, ataxia, slurred speech, and confusion. His measured phenytoin level is markedly above the therapeutic range, far higher than the small dose increase would predict. Read the command. Which property explains the disproportionate rise? Phenytoin, small dose increase causing a large level rise with toxicity. Zero order saturable kinetics. Phenytoin exhibits zero order elimination kinetics at therapeutic concentrations. The enzymes that metabolize it become sodorated at clinically used doses, so a constant amount of drug is eliminated per unit time, regardless of concentration, not a constant fraction. Once the metabolic capacity is maxed out, even a small increase in dose overwhelms the system, and the serum level rises disproportionately and unpredictably, quickly entering the toxic range. That is exactly what happened here. A modest dose bump produced a large toxic level rise with the classic cerebellar toxicity, nystagmus, ataxia, slurred speech. The correct answer is D. The three classic zero-order drugs are phenytoin, ethanol, and aspirin at high doses, PEA. Contrast with first-order kinetics, where a constant fraction is eliminated and levels scale predictably with dose. Because of this saturable behavior, phenytoin requires careful dose titration and level monitoring. The disproportionate, nonlinear rise is the fingerprint of zero-order kinetics. Which organism is responsible? A 58-year-old man with acute myeloid leukemia and prolonged neutropenia develops fever, pleuritic chest pain, and hemoptysis. CT chest shows nodules with surrounding ground glass. Halo, sign, and a cavitating lesion. Biopsy shows septate hyphae branching at acute 45-degree angles invading blood vessels. Read the command. Which organism? Neutropenic leukemia patient. Pulmonary nodules with halo sign. Septate hyphae branching at 45-degree acute angles. Angioinvasive, invasive aspergillosis. Invasive aspergillosis is caused by Aspergillus fumigatus, a mold that becomes dangerous in profoundly immunocompromised neutropenic patients, such as those with AML or after transplant. The diagnostic histology is the key, septate hyphae that branch at acute, roughly 45-degree angles. Aspergillus is angioinvasive. It invades blood vessels, causing thrombosis, infarction, and hemorrhage, which produces the hemoptysis, the pulmonary nodules, and the CT halo sign, a nodule surrounded by ground glass hemorrhage. The correct answer is B. The critical contrast is with mucor. Choice C, which causes mucormycosis with non-septate, broad, ribbon-like hyphae, branching at wide, roughly 90-degree angles, classically in diabetics with DKA, invading the sinuses and brain. Septate, 45-degree, acute angle branching equals aspergillus. Non-septate, 90-degree wide angle equals mucor. Treat invasive aspergillus. Non-septate, 90-degree wide angle equals mucor. Which type of vaccine is contraindicated and why? A 12-month-old child with a severe combined immunodeficiency (CIST) is being evaluated. The parents ask which routine childhood vaccines are safe. The pediatric immunologist explains that certain vaccines are absolutely contraindicated in this child. Read the command, which vaccine is contraindicated and why. CID patient. Live attenuated vaccines are contraindicated because the organism can disseminate without functional immunity. Live attenuated vaccines are absolutely contraindicated in patients with severe immunodeficiency such as CID. A live attenuated vaccine contains a weakened but still replicating organism. In a healthy person, the immune system controls its replication while developing a strong, durable response. But in a patient with no functional T cell or B cell immunity, there is nothing to contain the organism. It can replicate unchecked and cause disseminated, potentially fatal infection from the vaccine strain itself. Examples include MMR, varicella, oral polio, BCG, and the live attenuated influenza nasal spray. The correct answer is C. Inactivated, toxoid, and subunit vaccines are safe in immunodeficiency because they contain no living organism and cannot replicate, though they may be less effective if the immune response is impaired. Live attenuated vaccines are also generally avoided in pregnancy and in patients on significant immunosuppression. No functional immunity plus a replicating vaccine organism is the danger. Blockade is done. Let's review the 5 biggest traps from this block. Trap 1. How 2 drugs lower GFR from opposite ends. NSAIDs block the prostaglandins that dilate the afferent arteriole, so it constricts. ACE inhibitors block the angiotensin II that constricts the efferent arteriole, so it dilates. Both can crash GFR in a vulnerable kidney. Trap 2. In an at-risk alcoholic, giving glucose before thiamine can trigger or worsen Wernicke encephalopathy. Always give thiamine first. The confusion, ophthalmoplegia, and ataxia triad is the clue. Trap 3. Inferior MI from the right coronary artery can involve the right ventricle, making the patient preload dependent. Give fluids and avoid nitrates, which would drop preload and cause severe hypotension. Trap 4. The moles. Aspergillus has septate hyphae branching at sharp 45-degree angles. Mucor has broad non-septate hyphae branching at wide 90-degree angles, classically in diabetic ketoacidosis. The branching angle separates them. Trap 5. Live attenuated vaccines are contraindicated in severe immunodeficiency. The weakened organism still replicates, and without functional immunity, it can cause disseminated disease. Inactivated and subunit vaccines are safe. Train process, not memorization. 8 blocks complete, 160 questions of train reasoning. StepLogic, learn how to think, not memorize.